Thank you, and welcome everyone. And I hope you'll enjoy this discussion we'll have tonight on monitoring prostate cancer to guide treatment decision making. So this is a presentation that was developed by Dr. Sebastian Hutt, medical oncologist at McMaster University, Ricardo Rendon, urologic oncologist at Dalhousie University, and myself here in Montreal at the University of Montreal. And you have the disclosures listed here. And all faculty have adhered to the Code of Ethics, the CMA guidelines for physician interactions, and Innovative Medicine Canada Code of Ethical Practices. This program was initiated and supported by Prostate Cancer Canada with educational grants from Janssen and Astellas. And Tal Erdman at the CUA, who is the coordinator of CPD programs and accreditation, is the person you should contact if you have any comments regarding this educational program. So the objectives here, and it's going to be a relatively large overview of managing prostate cancer in the metastatic and in the CRPC settings, is to assess and identify men with advanced prostate cancer, evaluate the risk for disease progression or recurrence, and to try to establish a monitoring plan for these patients, and to address some of the treatment-related side effects, and to develop treatment and referral patterns for patients with metastatic hormone-sensitive as well as castration-resistant prostate cancer. Given the evolving treatment landscape, it's becoming more and more difficult for everyone to do everything. And so I think understanding where the field is headed and what we can offer patients, whether ourselves or in collaboration with others, is critically important. So briefly, we're going to have a brief introduction. We'll talk about some of the issues regarding hormone-sensitive metastatic prostate cancer, non-metastatic castration-resistant prostate cancer, and the metastatic castration-resistant prostate cancer setting. So in terms of natural history of prostate cancer, this has been pretty much the states model we've been using for several years now, since the Prostate Cancer Working Group 2 came out. And what I think is most impressive is that where we've had very little to offer in terms of novel therapies beyond ADT for almost 50 years, looking at this slide, you realize quickly that there have been a lot of phase 3 studies that have led to approvals of several agents in the settings of metastatic hormone-sensitive disease, in the setting of metastatic castration-resistant disease, and most recently in the setting of non-metastatic castration-resistant disease. So I think it's really exciting that we have a lot of things to offer patients at the different states of prostate cancer. So if we start with the metastatic hormone-sensitive setting, here we have docetaxel and abiraterone that were studied in both CHAARTED and STAMPEDE, and in terms of abiraterone studied in LATITUDE and STAMPEDE also, and there was the GTUG study done in France using docetaxel. So very briefly, just as an introduction in terms of the discussion, this is a 67-year-old patient who would present, and then, it's unfortunate, but we still see these patients. And again, this week I saw 2 patients that had PSAs of over 100 as first introduction to prostate cancer. This patient came in with 180 of PSA. He has multifocal Gleason 8 disease on biopsy. And the question that we would ask here is, what would you order as tests at this stage of the disease? In this kind of patient, obviously bone scan is what everybody would consider doing up front, but I think with everything we know now from many of the clinical trials, it's clearly insufficient to limit to bone scans. So CT of the abdomen and chest is routinely asked, at least in our center, in patients that are at high risk of metastatic disease. And we include the chest here because lung metastases are more frequent than we would expect based on what we thought of the natural history of prostate cancer. And so now it's clearly important to have a chest x-ray. Other lab tests, clearly PSA obviously is already done. That's what led to the diagnosis and risk stratification. But also knowing the bone marrow function with at least a hemoglobin, alkaline phosphatase to give us a better idea of the tumor burden in the bone, and liver function tests, not only to know whether the patient is affected by possible metastases, but more importantly, for patients who are going to go on to therapy for metastatic disease, we need to know if their liver works properly, because many of the drugs that we use are limited by the liver function. And knowing the serum creatinine is very important, since the age of these patients, the underlying disease, often leads to poor renal function, and this also can limit some of the treatment options. And we need to check whether patients have obstructive disease when they present with such high-risk prostate cancer. The NCCN has similar recommendations, and here there's inclusion of consideration for tumor testing for molecular or genetic abnormalities that would lead us to maybe consider certain treatments that we wouldn't routinely consider, and also in terms of screening for patients who have high risk of disease if they are known to have BRCA in the family or other mutational genetic abnormalities. So this patient that presented with a PSA of 180, as expected, we did find metastases. This is a patient who has multiple bone metastases, spine, left hip, left femur. He has multiple lymph nodes in the retroperitoneum, and the chest x-ray is negative. So based on charted, this patient would be considered high volume disease because he has more than 4 bone metastases, and he has metastases in the femur and also in the ribs, as well as multiple lesions in the spine and in the pelvis. What other information is relevant in this case is his performance status is clearly important in decision making, but also in terms of prognosis and whether or not the patient has symptoms. So we have clinical trials now that have clearly showed that in this kind of patient, ADT alone would be considered insufficient. We have studies looking at the combination of ADT plus docetaxel, and other studies looking at ADT plus abiraterone, and the classic studies are CHARTED, STAMPEDE, and LATITUDE. And so CHARTED was really the first study to show that we can do more than ADT alone in terms of improving survival and reducing the risk of death. So patients were randomized to ADT plus docetaxel for 6 cycles versus ADT alone. And it was an all-comer population in this study. And what we realized is that patients who get upfront docetaxel versus ADT alone in the high volume setting have a significantly improved overall survival, 17 months improvement in overall survival, almost a 40% reduction in the risk of death. And I say upfront because patients who started on ADT alone, in fact, did get very good therapy when they became castration resistant, and the majority of patients ended up getting docetaxel when it was indicated. So this is really a study that shows that early docetaxel is much better than delayed docetaxel in patients who are high volume. This is not the case for patients who are low volume, where in this situation it's probably adequate to limit yourself to ADT and introduce subsequent therapies when patients progress to the castration-resistant setting. So in the low-volume setting, PSA, it was a hazard ratio of 1.0, so clearly no impression of improvement of survival, at least in the average patient, and in this case, average patient is close to 7 years old. So obviously there are exceptions, but overall, for the average patient, I would limit docetaxel to the high-volume setting and not really consider docetaxel in the low-volume setting. STAMPEDE had an arm with docetaxel and ADT versus ADT alone, and here they showed a significant improvement in overall survival in the metastatic hormone-sensitive setting with a 10-month improvement in overall survival. So Here, it looked like it would be maybe a little bit less effective than charted, but we have to remember this is the all-comer population, including both high volume and low volume disease, and it wasn't really tested to know whether the high volume had the same kind of outcomes as in charted. But clearly, 2 studies, randomized, controlled, showing that adding docetaxel improves overall survival. Latitude took a relatively similar population. Here it was high risk, newly diagnosed, hormone naive, metastatic, hormone sensitive prostate cancer, and the definition for high risk was 3 or more metastases, bone metastases, Gleason score of 8 to 10, and visceral metastases. And you had to have at least 2 out of 3 of these risk factors to be considered high risk. And patients were randomized 1-to-1 between ADT plus abiraterone plus prednisone versus ADT plus placebo. And in this study, now well known, there was an almost 40% reduction in the risk of death. So almost identical in terms of advantage to docetaxel in patients who started on abiraterone and ADT versus those that started on placebo plus ADT, with a 50% reduction in the risk of radiographic progression or death in those patients who started with abiraterone plus ADT versus placebo and ADT. So very significant improvements in both overall survival and delays in progression of the disease. What was found also in Latitude that was not as noticed in the docetaxel studies is that patients had improvements in quality of life compared to baseline in patients who started and stayed on ADT plus abiraterone versus those that started on ADT, where there was a slight improvement in quality of life at the beginning, but then very shortly after there was a worsening in terms of pain scores and in terms of quality of life in patients who started on ADT. Stampede also had an arm for abiraterone and ADT and showed almost identical results with a hazard ratio of 0.63, so a 37% reduction in the risk of death in patients who had abiraterone plus ADT versus ADT alone. So again, 2 randomized studies showing the same thing. So clearly, this is really level 1 evidence of the role for abiraterone in patients who are metastatic, newly diagnosed, and also the same for docetaxel in hormone-sensitive metastatic patients. And in looking at the subgroups, because here Stampede did include patients that were non-metastatic, it's the minority of the patients, but they did show improvement in delaying progression of the disease. But in terms of overall survival in the non-metastatic setting, there's a trend, but it didn't reach statistical significance in the non-metastatic setting in terms of overall survival, but clearly for the patients who were metastatic, hormone sensitive, a clear advantage in most patients for using upfront abiraterone versus delayed abiraterone when they became castration resistant. So again, improvements in overall survival in multiple studies for both docetaxel and abiraterone, and the definitions of both high risk and high volume are listed here, and this is important when we're dealing with patients who come in with metastatic disease, especially since we're more and more inclined to do adequate verifications of the status of metastases in patients who are at high risk of metastatic disease. So when we look at patients who got both abiraterone or docetaxel in a similar period, the only study that can help us to understand the potential differences in terms of outcome is the Stampede trial, because in the same period they were treating patients either in the abiraterone ADT arm or in the docetaxel ADT arm. So this is very important because it's contemporary. They were either randomized in one or the 2 arms, so we can at least get some impressions of whether or not there's an advantage of one over the other. So in terms of delaying progression of the disease, clearly this would favor abiraterone. We're starting with a very effective therapy, and it's continuing while they're still hormone sensitive and is delaying the appearance of castration resistance. So clearly in terms of failure-free survival, and this is driven mainly by PSA and sometimes by symptoms or radiographic progression. But in terms of overall survival, very difficult to see a difference between abiraterone or docetaxel in those patients who are newly diagnosed and metastatic. So looking at it in a different way, failure-free survival, advantage with abiraterone, progression-free survival, an advantage for abiraterone, metastatic progression-free survival, an advantage for abiraterone. In terms of skeletal events, quite similar results, maybe slightly favoring abiraterone, but when we talk about cancer-specific survival, overall survival, very similar outcomes. So it becomes a question of not so much efficacy in terms of survival, but in terms of quality of life and tailoring therapy to patients based on their risks and tolerability of different adverse event profiles of both drugs. So clearly, docetaxel is a therapy that's harder to tolerate, especially in the elderly patient. The advantage of docetaxel is that it's over a finite period, 6 cycles, 18 weeks, and it's finished. Abiraterone is going to be given on a much longer period, but in terms of tolerability, clearly very few patients are unable to tolerate the abiraterone plus ADT regimen. So here are the practical considerations of the pros and cons of each of the choices that need to be discussed with the patients and tailored according to both patient profiles and patients' preference. I think patients have to be part of this decision making. And there are still some patients where we'll give only ADT alone. And this is a disease where some patients are quite elderly, have quite comorbid conditions, and especially if they are a relatively low tumor burden in terms of metastatic disease, consideration could be given for some patients of ADT alone. So this patient that we talked about, 67 years old, decision making based on patient factors, based on tumor factors, and one of the tumor factors that I do look at when I try to decide whether I'm going to go with docetaxel or abiraterone is the PSA level at which they were found to be metastatic. So a patient with widespread metastatic disease with a low PSA level makes me wonder if there is a truly large proportion of the disease which is truly hormone insensitive and where early chemotherapy would be a benefit. Also, the site of metastases needs to be considered. So patients who are predominantly liver metastatic disease, there would be consideration that maybe early chemotherapy would need to be done. And in patients who are exclusively liver metastatic, I would suggest strongly that these patients would need a biopsy to truly understand whether it's a high proportion of neuroendocrine disease, which could completely change the way we would treat this patient. And then treatment considerations for patients to consider is whether they would prefer a short-term aggressive therapy or a longer-term softer therapy to tolerate. And when we're deciding on treating patients with abiraterone, there are slight differences whether we're treating them in the hormone-sensitive or CRPC setting. So in terms of dosing, they're the same. But in terms of prednisone, the studies used 5 milligrams once a day for the hormone-sensitive. So it's 5 milligrams total versus 10 milligrams. Sorry for the little typo in this slide. But the monitoring remains the same whether or not you are hormone sensitive or castration resistant. The first 3 months, important to have liver function tests to make sure there are no abnormalities that appear. A relatively rare event, but needs to be captured early if there are issues. Blood pressure, serum potassium, and fluid retention should be checked on a monthly basis. And patients are relatively well, tolerate the drug relatively well in the vast majority of patients. So during treatment, PSA should be done, at least for most patients who are hormone sensitive, metastatic, at least every 3 to 6 months. Personally, I would tend to go at least every 3 months in patients who are responding very well. In terms of imaging, the recommendation I usually give is that we need imaging obviously at baseline to determine that they're metastatic. When patients reach their nadir in terms of PSA, that we have the maximal response, I like to get a new imaging to reestablish the new baseline and determine to what extent they had radiographic response. And then after that, I would do a minimum imaging when they progress to a castration-resistant setting where PSA is rising, or if they have symptom progression, re-image the patient. So this would be really a minimum. For most patients who are doing very well, at least PSA-wise and symptom-wise, I would usually get an imaging once a year to make sure there's no discordance between what looks like stable disease. And I would also monitor, obviously, PSA, but also alkaline phosphatase and LDH, and clearly symptoms. And if there's a change in any of these, I would consider imaging before deciding to change therapy or to keep the same therapy ongoing. There are issues regarding flare phenomena, both with chemotherapy and with the hormonal agents. And here we have to be careful that we don't discontinue therapy too early because of the impression of progression, either PSA-wise or imaging-wise. And so if patients look like there's a discordance between their clinical response and imaging or PSA, these have to be repeated, especially imaging can look like it's getting worse when it's performed in the first 3 months, and I would recheck at least 6 to 12 weeks later to see if there really is progression or stabilization of the disease. So how do we establish true progression? Obviously, it's not one single element that we use, definitely not only PSA, but PSA plus imaging changes or symptom changes or performance status deterioration. So if you have any of two of these characteristics, I think we have to strongly consider the patient is progressing, restage them, and then decide on going on to a subsequent therapy. What you don't want is to be waiting too long and maybe limit patient opportunities to going on to subsequent lines of therapy. In terms of the non-metastatic CRPC setting, this has led to a lot of excitement since until very recently, until last year, we really had no therapeutic options for patients who were non-metastatic but had reached the castration-resistant setting. So in this scenario, we now have 2 agents approved in Canada based on PROSPER study that used enzalutamide and the Spartan study that used apalutamide in the non-metastatic castration-resistant setting in the high-risk population. And so this is a case in point of a patient, a retired dentist who was diagnosed with a high-risk prostate cancer, PSA of 32, Gleason score 4+5. Imaging had a solitary lymph node on CT scan in the pelvis, and he had radiation therapy plus 3 years of ADT. While he was still on ADT, PSA started to rise slowly. He had a nadir that went down to 0.8 from a baseline of 32. Testosterone was well maintained, but he went from 0.8 to 1.7, so not yet CRPC, but then he continued to rise, so he reached 2.5, so clearly CRPC, and then continued to rise up to 10.5 of PSA, with a PSA doubling time that was calculated to be 4.5 months. And this patient was imaged at the time he became CRPC, imaged when it 6 months later, and again imaged about 4 months later, and all of these images showed no metastases. And here we are still using conventional imaging of CT and bone scan. It's still not an approved regimen to be doing PSMA. And, most of us would expect that if he had a PSMA, we would probably capture something somewhere, but conventional imaging is still the standard imaging being used around the world. and is the imaging that was used for the clinical trials that led to the approval of the agents we're talking about today. So this patient, doubling time 4.5 months, so clearly high risk of a doubling time of less than 10 months, and even higher risk because it's below 6 months, no evidence of metastases. So we know that rapid doubling time leads to earlier metastases and death based on 2 randomized phase 3 studies. And in terms of actual death based on PSA doubling time, there's populational data that shows the same thing. We presented data at last year's AUA looking in the population, again, outside of clinical trials. Metastases-free survival is clearly much shorter in patients with doubling times of less than 10 months, and overall survival is significantly shorter in patients with doubling times of less than 10 months. So we have clinical trials, Spartan and Prosper. So Spartan randomized patients considered high-risk, non-metastatic to either getting apalutamide or placebo in a 2-to-1 fashion. Patients had to have doubling times of less than 10 months, had to continue ADT, and the primary endpoint was metastases-free survival, with several other important secondary endpoints. So most importantly, the primary endpoint of metastases-free survival was clearly met. It surpassed our expectation, 72% reduction in the risk of metastasis or death. This was about a 2-year improvement in delaying metastases in this high-risk patient population that became metastatic on the placebo arm within about 16 months. There was a 71% reduction in the risk of local or distant metastasis or death, so very similar, but you see that the placebo arm had these events even earlier because now we're including local progression, which is an issue in patients, especially if they didn't get good local control earlier on in their disease trajectory. There was also a trend towards an overall survival improvement, a 30% reduction in the risk of death that didn't reach statistical significance, but heading in the right direction. And this is important when we consider the patients on the placebo arm were actually treated with subsequent therapy when they became metastatic very early, and much earlier than we would do in the real-world setting. In terms of PSA progression, clearly there's no comparison. It was a 94% reduction in the risk of PSA progression in patients on apalutamide compared to placebo. And in terms of quality of life, and this is what's, I think, most intriguing, is that there were obviously adverse events that were reported during the study. Patients were seen often. They were being asked on a regular basis if they were having any adverse events or any complaints, if you want. But overall, even though there were more adverse events, more complaints on apalutamide than on placebo, obviously. Patients were also on apalutamide much longer than on placebo. But overall, the impact on their daily quality of life was minimal. If anything, we were seeing slightly worse quality of life on placebo because patients were starting to progress as time went on in the placebo arm. So this was very reassuring that we kept patients with good quality of life as they stayed stable in terms of prostate cancer with apalutamide. When we asked specific questions about how they were bothered by side effects, saw very little difference between apalutamide and placebo. So in conclusion, significant delay in metastases-free survival, improvements across the different evaluable endpoints of PSA, PFS, OS, and PFS2 in terms of subsequent progression when patients went on to subsequent therapy when they became metastatic. And it was well tolerated. Prosper had a very similar design. This was using enzalutamide that we routinely use in the metastatic CRPC setting, so a drug that we know very well. So patients, again, randomized 2-to-1, enzalutamide versus placebo. In the high-risk, non-metastatic CRPC setting, doubling times of less than 10 months again. And again, metastases-free survival as being the primary endpoint with several secondary endpoints of importance. And almost identical to Spartan with apalutamide, here was a 71% reduction in the risk of metastases or death. And we see that the placebo patients became metastatic in less than 15 months, whereas it took almost 37 months on the enzalutamide arm to become metastatic. So a 22-month advantage in terms of delaying metastases or death in the patients who received upfront enzalutamide. And again, a very interesting trend towards an improvement in overall survival in those who started on enzalutamide. And again, the placebo arm is, in my opinion, doing better than the real world, since patients were followed very closely, and as soon as they became metastatic, the vast majority of these patients went on to effective therapies for the metastatic CRPC setting that were available to almost all the investigators and the patients that were on this study. So clearly, we're seeing trends to overall survival that were actually unexpected, since patients were followed so closely, and as soon as they became metastatic, got access to very good subsequent therapies. Again, very similar in terms of reducing the risk of PSA progression, with a 93% reduction in the risk of PSA progression in patients who started enzalutamide compared to placebo. And again, very reassuring in this early disease setting of CRPC, where patients are clearly asymptomatic since they're non-metastatic, that enzalutamide had no significant impact on quality of life, and patients remained stable whether they were on placebo or enzalutamide, which was very reassuring in this patient population. So enzalutamide decreased the risk of metastasis or death by 71%, prolonged MFS by 22 months in patients with high-risk non-metastatic CRPC, and all the evaluable endpoints were consistent in terms of improving outcome, both in terms of progression-free survival, time to PSA progression, and overall survival. So again, enzalutamide was well tolerated in this patient population and maintained quality of life. So how do we decide whether or not we treat in the non-metastatic CRPC setting? But clearly, the most important factor is PSA doubling time, since clearly patients with slow rising PSA do generally very well for a long time. So clearly no indication to treat somebody who has a slow rising PSA. But in patients with rapidly rising PSA, we now know that these patients are at high risk of both metastases and death. We also need to consider absolute PSA values, which were not considered in the clinical trials. But in the real world, PSAs of over 20 are patients at risk. So these patients need to have more consideration and closer follow-up to determine whether or not they should be treated. Other factors that play some form of consideration is time from ADT to becoming CRPC. Obviously, life expectancy is important. So a very elderly patient who has a PSA doubling time that's short, I think we know these patients can live several years, even though they have a short doubling time. And so life expectancy for the first time needs to actually be considered in the CRPC setting when the patients are non-metastatic. And clearly the patient has a big say into whether or not he's going to undertake treatment in this setting or wait till they become metastatic. In terms of adverse events, again, even though there were adverse events more commonly reported with both apalutamide and enzalutamide, the placebo patients also complained of adverse events, even though we know placebos shouldn't really have adverse events. And that's why it's important to not only look at the drugs, but also the placebo arms. And when you look at this, the differences are not substantial. There are slight increases in terms of risk for patients, but overall their quality of life was well maintained, especially when we choose patients who are more likely to benefit than to be harmed by these drugs. So how do we monitor these patients? Obviously, these patients need to have regular testosterone checks to make sure that they're adequately castrated, since these drugs can never be used alone without ADT. PSA needs to be followed, and basically symptoms. If patients are stable PSA-wise, symptom-wise, probably we can monitor these patients annually in terms of imaging rather than on a regular basis. If PSA does progress, then imaging is clearly indicated to make sure that they haven't become metastatic, and the sites and the number of metastases will play a role in deciding what the subsequent therapy will be. So we'll take the last small section on metastatic CRPC that we've been talking about for several years now, since we've had several different agents available. So this patient who we first saw with metastatic hormone-sensitive disease, with 180 PSA, multiple METs that we saw up front in the presentation, ended up getting 6 cycles of docetaxel plus ADT. 3 months later, we see a reduction of bone METs, a disappearance of lymph nodes METs, so clearly a very good response. 24 months later, the PSA is increasing. It's up to 6. There's an increase in bone and lymph node metastases. Patient is still feeling well, is asymptomatic. He's got normal lab tests. So at this stage, the patient is clearly metastatic CRPC. And the question is, what do we treat them with? So in patients who got docetaxel in the hormone-sensitive setting, if we retreat them with docetaxel, very few patients actually get good responses. And this was seen with the GTUG study that was published about 1.5 years ago with very few responders. Whereas if we go from hormone-sensitive docetaxel to abiraterone or enzalutamide, we have a much higher chance of having a response, where 86% of patients will get a response in terms of PSA. And most of the experts at St. Gallen's conference would suggest going with a hormonal approach if patients had gotten docetaxel in the hormone-sensitive setting, rather than re-exposing patients to more chemotherapy. And this is well known, since we've known that abiraterone and enzalutamide are effective in the post-docetaxel setting. So there was no reason to expect it to be any different if they got the docetaxel in the hormone-sensitive metastatic setting. So there's no real level 1 evidence in terms of sequencing, but in the different scenarios that we're going to be facing more and more over the next few years, if patients get apalutamide or enzalutamide in the non-metastatic CRPC setting, most would consider that repeating hormonal approach is probably not what's most effective, and probably docetaxel would be the first choice in those patients outside of clinical trial setting. If patients got abiraterone in the hormone-sensitive metastatic setting, again, going from abi to enza, we wouldn't expect tremendous responses. There are some patients who might respond, but the majority will not get long-lasting responses. And again, probably a chemotherapeutic approach would probably be the most reasonable if patients progressed on abiraterone who started in the hormone-sensitive metastatic setting. In those who get docetaxel in the hormone-sensitive metastatic setting, re-challenging with docetaxel was something we used to do, even though it probably isn't the most effective therapy. Probably the most effective therapy is to going to the hormonal approach, where we have level 1 evidence that hormonals work well after docetaxel. There's also the possibility of combining abiraterone with a PARP inhibitor. This was the basis of a phase 2 study that was reported last year and published, and now there's an ongoing phase 3 study. And radium after docetaxel, there is data to support that patients who have predominantly bone metastatic disease might benefit from radium as a first line of therapy after docetaxel. So if the scenario is a patient is worse clinically, but PSA is not rising, this is an issue that we do worry about, because patients without PSA rise but clinically deteriorating, especially with radiographic progression, could indicate a transformation to a neuroendocrine or a small cell feature, and these patients need to be getting chemotherapy with a platinum-based approach most often, and really close collaboration with the medical oncologist is clearly 100% required if they haven't been involved already from an earlier state of the disease. And so we do look at other parameters besides PSA. LDH is a very powerful predictor of outcome and survival in the metastatic CRPC setting, same as alkaline phosphatase, very powerful predictor. And these two predictors, just being above the upper limit of normal, actually have more weight on a nomogram than PSAs of over 1,000. And so these are parameters that clearly need to be looked at to give a better idea of the overall patient that we're treating. So this is, again, just a management scheme for patients with metastatic CRPC. One, ADT needs to be considered in all patients. Patients who have bone metastatic disease, denosumab or zoledronic acid to delay and to reduce the risk of skeletal-related events. Palliative radiation, best supportive care is clearly always needed in these patients. And then systemic therapy, if patients are negative for visceral metastases, abiraterone, prednisone, enzalutamide, even docetaxel can be considered. Radium-223 could be considered for symptomatic bone metastases. These different options should be discussed with patients. For the vast majority of patients, it will be a hormonal approach as the first line with abiraterone or enzalutamide in the mCRPC setting. If patients have visceral metastases, to consider biopsy to assess whether other types of chemotherapy should be considered. So the main takeaways from this presentation is that in the metastatic hormone-sensitive setting, these are the list of recommendations in terms of baseline evaluation and then monitoring and re-imaging as patients progress or remain stable. In the non-metastatic CRPC setting, monitoring PSA doubling time in order to establish the risk of disease progression. And if patients have a doubling time of less than 10 months and especially less than 8 months, these are truly considered high risk and should be considered for treatment if they have good life expectancy and are motivated to treat earlier rather than later. And then in the metastatic CRPC setting, baseline evaluation, symptoms are very important, and all of the 8 parameters that were listed in the prognostic factors are clearly important and to keep in mind whenever we see a patient in the metastatic CRPC setting. In terms of imaging, usually I will re-image when PSA progresses or if patients have clinical progression. But if patients are very stable, I will re-image at least once a year, because there are patients who do progress without any PSA progression that we need to be aware of when they are well controlled with drugs like abiraterone or enzalutamide. And there are still a lot of ongoing studies in prostate cancer in the different disease settings. So clearly, this is a field in cancer that is continuing to evolve, and we're going earlier and earlier now, even in the hormone-sensitive non-metastatic setting where several trials are ongoing and others are going to report soon in the metastatic setting. Already Arches reported just a few weeks ago. Titan is going to report soon officially, and Arisense should be reporting in the future, where we're going to be looking at the combination of chemotherapy plus a novel hormonal therapy plus ADT in the upfront. Arisense is in the non-metastatic. Aramis is in the non-metastatic with darolutamide, and Arisense is in the metastatic hormone-sensitive setting, where we're actually testing the triplet model of chemo plus hormones plus ADT. And in the mCRPC setting, there's still a lot of work now in combinations with PARP inhibitors and even with some PD-L1 inhibitors that are being tested.